Now, here to talk with us about the multiple myeloma abstracts being presented at the 2018 ASCO annual meeting is Dr. Sagar Lonial, who is professor and chair of hematology and medical oncology at Emory University School of Medicine and chief medical officer at Winship Cancer Institute. Welcome, Dr. Lonial. Thank you for joining us today.
Thank you for having me here.
Sure. So it's been such an interesting year in multiple myeloma, especially in recent years too. Can you share your insight on the wave of CAR T-cell therapy that's been coming through the landscape, specifically with BB2121?
Yeah, I think the CAR T-cell world is something we in myeloma have been a little bit late to the game on. Large cell lymphoma and ALL is well ahead of us with approvals already. And we've seen a spattering of data, first looking at CD19 as a potential target, probably not the optimal target, but then an explosion of 4 different BCMA-targeted phase 1 trials demonstrating pretty significant activity. BB2121 was updated today now, or at this meeting, and demonstrated not only a high overall response rate, 90+%, but a median progression-free survival of almost a year. Now, I think that you can look at that as glass half full or glass half empty. I think practically speaking, 12 months is much better than the data we've seen in the approved large cell lymphoma trials, where the median PFS was about 3 to 3.5 months. So I think it's clearly a step forward, and understanding which are the optimal patients to treat is the next step.
So let's say BB2121 gets approved in the landscape. How do you think that might affect sequencing for therapies?
Well, I think what's going to happen is that the use of CAR T cells is going to move earlier and earlier in the disease process. Clearly, as cells become more resistant, they acquire new mutations and become genetically more complicated. And so getting to those cells earlier is probably the way to go. And I know there are many trials planned in early relapse, as well as potentially either comparing with transplant or even in the post-transplant setting.
Great. Okay. So now let's look at the phase 3 Optimism trial. So that's another interesting finding. Can you share your insight on that, and how could these results potentially change standard of care?
Yeah, so Optimism really came at a great time. We had several trials in 1 to 3 prior lines of therapy where lenalidomide and dexamethasone was the control arm. And so what you know is in len-naive patients, a triplet, whether it's carfilzomib, elotuzumab, ixazomib, dara, whatever drug you want to pick, was better with len-dex versus len-dex. Optimism actually gave us a pom-dex control arm, which is most relevant to our patients in the US because most of them are progressing on lenalidomide maintenance. So it gives us another treatment approach for patients who are progressing on len maintenance.
Good. Okay, great. And now we also saw data exploring a different dosing schedule with carfilzomib in the ARROW trial. So what are your thoughts on that study? Is there enough data there to change practice?
Yeah, the ARROW study was really a very interesting idea, taking the twice-a-week dosing of carfilzomib at 20/27 compared to 70 once a week, and clearly showed a pretty similar safety profile and a much higher progression-free survival favoring the once-a-week dosing. It probably has to do with dose intensity, which is a good thing, and I think does have the potential to change practice for carfilzomib across the board.
Nice. Okay, great. Now, there was another phase 2 study that highlighted the triplet of venetoclax, carfilzomib, and dexamethasone. So what's really the rationale in using this type of regimen, and what kind of data did we see there too?
Well, what we know about venetoclax is that clearly it has activity in 11-14 positive myeloma patients. That's not all of them, but if you look at data presented by Jonathan Kaufman from our group on behalf of the study group, almost 70% of patients with 11-14 respond to venetoclax index. So that gives you a really good background. We also know that carfilzomib is highly effective, as we saw from the ARROW trial, partnered with dexamethasone. So putting the two together, I think, does make sense. What's hard to tease out from that trial results is how much of the contribution was carfilzomib and how much of the contribution was venetoclax. And I think we need larger randomized trials to really answer that question.
Very good point, definitely. Now, you're the lead author on the study of the 5-year follow-up of the ELOQUENT-2 study. So what's to make of the longer follow-up here?
Yeah, I think it's really exciting because having sort of been with ELO since the original phase 1 study, it's kind of neat to see the 5-year follow-up. What we see is that the benefit for ELO Lendex continues to be maintained at about 30% over Lendex. Clearly that many trials with longer follow-up, the PFS curves come back together. They did not with this trial. The second is that the overall survival data continues to look more and more robust, again suggesting that you're not only getting a PFS benefit, but a survival benefit as well.
Good. All right, wonderful. And then So earlier this past year, we did see some disappointing findings with immunotherapy combinations in multiple myeloma, specifically with Keynote 183 and Keynote 185. So could immunotherapy still have a role in the landscape of multiple myeloma?
Absolutely. I think the question really revolves around what is the optimal partner for PD-1 or PD-L1? What's the right patient population? And I think that those trials are being done now. They're just being done a little bit more slowly. And for instance, we've heard that nivolumab is coming back in myeloma, at least to continue to enroll. So we know that PD-1 is not dead in myeloma. I think we just have to figure out where and when to use it.
Good. Okay, good points. Now, what other abstracts in multiple myeloma are you really excited about learning about at this meeting?
Well, I think there's a lot of different data, long-term follow-up on DARA, long-term follow-up on ELO other than ELOQUENT-2, some combinations with ELO looking at POM plus bortezomib, and I think we may very soon also potentially see some data on POM plus ELO in the relapse setting, and then beginning to look at maintenance and how does maintenance impact long-term outcomes. These are really interesting things that I think are coming in the next few weeks.
And so, just judging by all the research that we now have this year, what does this really say about the way that multiple myeloma treatment is moving towards?
Yeah. I think it's really exciting for patients and for the docs that take care of these patients. And the reason is, if you look at a series of patients from our center, almost 1,000 patients, the 10-year survival of patients with myeloma treated on our database is 70%. 70%. That was a disease where the median survival was 3.5 years just a decade ago. So I think figuring out how and when to use all these drugs together is the challenge for the next few years.
Definitely. Well, Dr. Lonial, thank you so much for joining us here today. We really appreciate you taking the time.
Thank you for having me.
Great. Thank you.